recording. There you go.
Okay. Paula, can you jump back on for just a second? I have one question for you. I need you to help me with an introduction. So my only communication with our next presenter has been through email and text. Stephanie, I do not know how to pronounce her last name.
Stephanie Ibemere. She worked with me really hard on that.
Yeah, I knew you would know her.
I know her.
All right, so Stephanie Ibemere, along with Dominique Bulgin, have presented or have submitted a video. They're going to co-present together. So I'm going to go ahead and read both of their bios, and then we'll turn it over to Kevin to run their video. So Stephanie is a PhD RN and is an assistant professor in the Duke University School of Nursing. Dr. Ibemere received her PhD in nursing research from the University of Cincinnati. Dr. Ibemere is a registered nurse with experience in global health capacity building and clinical education related to sickle cell disease and other chronic diseases. Her research program focuses on building healthcare provider capacity to deliver high quality and effective care for chronic disease symptom management. In particular, she is focused on improving the clinical model of care for sickle cell disease in low to middle income settings, both in sub-Saharan Africa and in the United States through tool adaptation, implementation science, and community engaged research. Dr. Ibemere is passionate about addressing healthcare disparities in partnership with communities to co-create feasible and sustainable healthcare interventions for and with patients, providers, and the health system. Dominique Bulgin, PhD RN, is an assistant professor at the University of Tennessee College of Nursing. She holds a Bachelor of Science in Nursing from Neil Hodgson Woodruff School of Nursing of Emory University and a PhD in Nursing from Duke University School of Nursing. Dr. Bulgin's research experiences include conducting secondary quantitative and qualitative analysis to explore factors that influence health behaviors and conducting a multi-site mixed methods global study that focused on uncovering the influence that stigma has on quality of life and self-management behaviors in adults with sickle cell disease in Jamaica and the United States. Her research interest includes improving health outcomes in adults with sickle cell disease by promoting disease self-management and mitigating the influence of social drivers of health and stigma. Just by way of a heads up, their presentation is specifically titled Nursing Implications of Care, but speaking for all nurses, we want our patients to understand those implications of care. And also we work closely with other multidisciplinary folks. And I think sharing, having insight into another discipline is important also to other disciplines. So I think we're ready to roll, Kevin.
Okay, see if I can get this playing. Can everybody see the video?
I see it.
Hello,
Okay.
and welcome to this webinar. My name is Stephanie Ibemere, and I'm joined by Dominique Bulgin. And we're here today to talk with you guys about nursing implications of care for individuals with sickle cell disease in the emergency department. So as I mentioned, my name is Stephanie. I am a nurse scientist and assistant professor at the Duke University School of Nursing. My research focuses on building provider capacity for sickle cell disease management in low to middle income regions around the world. And
So we're working on fixing the audio.
Hello and welcome to this webinar. My name is Stephanie Ibemere and I'm joined by Dominique Bulgin. And we're here today to talk with you guys about nursing implications of care for individuals with sickle cell disease in the emergency department. So as I mentioned, my name is Stephanie. I am a nurse scientist and assistant professor at the Duke University School of Nursing. My research focuses on building provider capacity for sickle cell disease management in low to middle income regions around the world. And I will let Dominique introduce herself and give you a bit about her research expertise.
My name is Dominique Bulgin. I am an assistant professor at the University of Tennessee College of Nursing. And my research interest focuses on improving health outcomes in adults with sickle cell by promoting disease self-management and mitigating the influence of social drivers of health and stigma.
Thank you so much, Dominique. We appreciate that. So we're going to go on to talk a little bit about the objectives that we have for this presentation. So for this presentation, we're hoping to give a brief overview of the pathophysiology of sickle cell disease and how that relates to some of the NANDA nursing diagnoses that are associated with sickle cell disease care in the emergency department. We're also hoping to help you understand some of the strategies you can use to mitigate stigma at both the individual and systematic levels. And then finally, we're going to talk a bit about strong patient-nurse communication and shared decision-making. So this graphic is just to give you a brief overview of the pathophysiology of sickle cell disease. Essentially, there's a moment at which sickle hemoglobin polymerize or change shape, and this leads to a cascade of a number of events. But essentially, this diagram is to show you what the problem really is at the level of the cell. So in this next slide, I'm going to take the pathophysiology one step further. And this diagram is meant to spell out the factors which precipitate sickle hemoglobin polymerization, or the change of shape that red blood cells go through to cause the sickling crisis. So essentially, any situation in which the oxygen demand increases in the body, for example, in dehydration or when someone has an infection, sickle hemoglobin will polymerize or change shape. So when this polymerization occurs, these sickle red blood cells become rigid and sticky and can directly impact the vasculature by blocking blood flow, leading to tissue hypoxia. But this structural change or polymerization can also lead to hemolysis because these sickle red blood cells are not as pliable as normal red blood cells are and easily break open when rushing through the blood vessels and through organ systems. So this hemolysis actually contributes to the anemia persons with sickle cell experience and further reduces oxygen carrying capabilities while increasing oxygen demand, which just creates a vicious cycle and incites further sickle cell polymerization or red blood cell polymerization to form sickle cells. The molecules released during this process of hemolysis lead to chronic vascular damage and create a persistently inflamed environment. So considering that, some of the common nursing diagnoses that are related to sickle cell disease, which nurses can develop care plans for, are right here. So the thing that I want to highlight, though, is to take note of some of the serious implications that a sickle cell crisis can have that aren't necessarily always pain. So I want you to take particular interest here in this idea of ineffective tissue perfusion. So we're actually going to talk about that here in the next few slides. But first, I want to talk about one that maybe isn't as talked about as pain might be, which is the risk for infection. And this is quite literally related to the fact that those sickle cells, as you saw in the very, very first picture, can block the vasculature. And this is particularly true in those really small vessels of the body, many of which are in the spleen, are, for lack of better term, our proverbial cheesecloth or our proverbial filter in our bodies that keeps us healthy. So one of the reasons that risk for infection is part of a nursing care plan for a patient with sickle cell disease presenting to the emergency department is because they often are functionally asplenic, or in other words, they have a spleen, but it doesn't work anymore because it's been damaged so badly by a sickle cell crisis. And then on top of that, you have the tendency, especially in the low to middle income setting, or even a rural setting, if you will, to have inadequate primary defenses, meaning there can often be leg ulcers that develop with sickle cell disease that put the very first barrier to infection at risk. In addition to the fact that there are many respiratory indications that are tied into sickle cell disease that can often put someone at risk for infection. So when you're talking about risk for infection, some of the things that you want to do to intervene, of course, would be to monitor the patient's vital signs. But in your initial assessment in the emergency department, you might want to ask your patients, and this is most likely part of whatever EMR system or electronic medical record system you're using, but you want to assess them for the signs of infection and find out if they've been, in this time of COVID, anywhere near someone that has had COVID, and determine whether or not they do in fact have a risk for infection. You're going to want to monitor labs such as the CBC with differential, and then initiate any antibiotic treatment that may be prescribed for a patient who is believed to have an infectious process as the cause of their sickle cell crisis. And then also you want to check the immunization history. This is particularly of interest right now in the low to middle income context, but in the beginning years, if you will, of understanding sickle cell disease in the high resource areas, it became clear that pneumococcal infection was really putting kids at risk for serious sequelae and serious sickle cell crises. As we said, infection can be a precipitant of sickle crisis. And so very early on, there was institution of pneumococcal vaccination for children for people with sickle cell disease, I should say. And so that's something that you would want to double check. Many of us are accustomed to hearing about, which is that a person has presented to the emergency department that has sickle cell disease and they're in severe pain. And this is really related to that very first picture I showed you. Imagine your blood flow is cut off to your extremities, to your joints, to your organ systems. That will be very painful. And so pain can be debilitating in this case. Pain can be throbbing pain, severe. Sometimes it's indescribable. But I want to make it clear that pain in this case is what the patient describes it as. It is subjective. And so you'll want to go ahead and work with the patient and gain their trust to be able to assess their pain and the intensity of that pain. But you might notice that the patient is guarding a certain part of their body or just guarding in general. They may have loss of range of motion. In my own experience, a lot of times it's a joint that will stop working all of a sudden, and then they get an excruciating pain or their back is hurting badly. Then you may also notice that the patient is really sort of closed in, self-focused, and that could be out of trying to deal with the pain, that could be out of not knowing what else to do, but you may notice that they are withdrawn, and that is part of a pain response. So again, what can we do, right? So we hear these things and what can we do? Well, one of the first things you can do is to provide a proper triage assessment. The National Heart, Lung, Blood Institute, as well as the American Association for Hematology, have recommended that analgesia administration should occur within 60 minutes or less for any patient that is having a sickle cell crisis. Lastly, we also encourage the use of individualized pain protocols if a patient has one, because those have been developed with their hematologist usually, and they are what works best for that patient. And so if you happen to come across one of those, we encourage you to use it, talk to your patient about it. They would appreciate hearing more and discussing more with you so that you can get to understand what it means for them to have pain management and to actually achieve their comfort and function goals. So I'm going to turn this over now to Dominique, and she's going to take it away.
Thanks, Stephanie, for that excellent overview of nursing care of sickle cell. So now I'm going to provide a brief overview of stigma of sickle cell and provide some strategies to mitigate stigma when caring for individuals with sickle cell. So health-related stigma is defined as the devaluation, judgment, or social disqualification of individuals based on a health condition. And people with sickle cell experience the gamut of health-related stigma as depicted in this conceptual framework. So there's labeling. People are often labeled as drug seeking or frequent flyers. There's social exclusion. People with sickle cell often feel like they are unwanted as patients, and this has even led to even more systemic issues like individuals having a hard time finding primary care doctors. There's also stereotyping. So people with sickle cell are sometimes accused of exaggerating or faking their illness, or accused of being lazy or being combative or difficult patients. And then there's also discrimination. So people with sickle cell are sometimes rejected by medical professionals or even receive substandard care. And on a systemic level, there is a lack of access to comprehensive care settings and for sickle cell disease. And finally, stigma is perpetuated through power imbalances that exist in society. So there's the power imbalance of the patient-provider relationship, and that relationship, the provider, of course, has more of the power. And there's also more systemic power imbalances in society through classism and racism that also perpetuate disease stigma. So one of the ways that disease stigma and racism is demonstrated in sickle cell disease is through comparisons through cystic fibrosis, or CF. So cystic fibrosis is also a monogenetic condition, but it affects less people. So you can see here that CF has about 30,000 people in the United States, whereas sickle cell disease affects between 90 to 100,000 people in the United States. However, sickle cell has higher incidence in Black births, whereas cystic fibrosis has a higher incidence in white births. And despite these differences in population, CF outpaces sickle cell disease in funding per person. So you can see here that funding per person affected is about $900 for sickle cell disease, whereas it's about $10,500 for cystic fibrosis. So the cause and perpetuation of these disparities in funding is linked to the stigma that these populations face and the lack of access to being seated at the table to sort of make the decisions that go into funding and research output. And the outcome of this disproportionate attention is further exemplified in the treatment options that are available to treat both of these diseases. You can see here that before 2007, there was only one drug to treat sickle cell disease, one disease-modifying drug, that was hydroxyurea, and it came out in 1998. Whereas, between 1993 and 2018, several drugs were FDA approved to treat cystic fibrosis, and the drug output in sickle cell didn't pick up until 2017 after a very long hiatus. So individuals with sickle cell experience both interpersonal and systemic racism. So the layered experience of health-related stigma and racism often compile and can become insidious for people with sickle cell. And this is evidenced through the systemic issues that I highlighted earlier in the comparison to cystic fibrosis. And also it can also be highlighted through comparisons to non-sickle cell African-American peers. So there's been studies that have shown that people with sickle cell have longer wait times than not only the general population, but also their non-sickle cell African-American peers. So this recently published perspective piece by Power, Hayes, and McGann perfectly summarizes the historical and present impact that disease stigma and structural racism in sickle cell disease stigma and structural racism in sickle cell. So, and how the disease stigma and systemic and interpersonal racism contribute to health disparities and equities in sickle cell disease. And in this article, they provided some proposed changes to reduce the impact of racism on patients with sickle cell disease in the United States. They proposed these in 3 different categories. The first was to reduce the impact of structural racism on patients with sickle cell. And some of the ways they recommended this could be done was through implementing universal screening for social determinants of health for people with sickle cell disease, reintroducing federal funding for comprehensive care settings, analyzing the effect of race and racism on federal funding for research, and providing psychosocial support for sickle cell disease. The second category was dismantling institutional racism with a focus on sickle cell. The first suggestion was to provide formal hospital-based reporting systems, similar to those for safety events, for responding to racist behavior, including patients with sickle cell disease and their advocates on anti-racism task forces, and instituting sickle cell specific pain management protocols to reduce the time to pain medication administration and improve health, and with an emphasis also on improving health outcomes. And finally, empowering patients with sickle cell disease to safely report concerns about racism and inequity. And the third category was addressing interpersonal racism with patients and colleagues. So the first suggestion that they gave was speaking explicitly about race within and across medical teams, developing partnerships with patients and recognizing their ability to educate providers about the impact of race and racism, and implementing annual racial implicit bias trainings for all clinicians in a supportive environment, practicing mindfulness and self-reflection in the care of patients with sickle cell disease and recognizing that everyone has biases, and stop using derogatory terms such as sickler and frequent flyer, and educating colleagues who use it, and creating safe spaces for healthcare providers to discuss race and racism and report events when they happen. So I highly recommend this article and the recommendations that they gave. So next, we're going to talk a bit about how nurses can mitigate stigma on an interpersonal level with patients. So I strongly, want to suggest the power of empathy and developing an empathy practice as a healthcare provider. So I'll start off with this very poignant quote from a sickle cell patient. "I have to be the best patient they've ever had in their life, because I want to make sure that the next time a sickle cell patient comes in, they at least get the basic care that they need." So you can see this person who's coming into the emergency department, probably in pain, is thinking ahead, being empathetic to the experience of the next patient, because they realize how stigma and the image that people have of sickle cell patients impacts the care they receive. So, if this patient is so empathetic that they're thinking that far ahead for the next person coming in after them, I think that we, on a individual level with patients, should be taking the onus to have, strong practices of empathy. So some of the tenets of empathy practices are that empathy is healing and judgment is harmful. So always sort of veer towards empathy and being empathetic when dealing with patients. Vulnerable populations unfortunately experience greater harm by judgment and lack of empathy, and that we all have judgments. So development of practice is about learning how to mitigate them and navigate your practice as a nurse. So just as you hone and maintain your nurse's skill, we need to hone and develop our ability to empathize with our patients. So it's important to be aware of your biases and the cues that trigger them, right? Be empathetic in your body language and your speech. Treat each patient as a new book. Each has their own unique story. So try not to harp on things that happened with a previous patient when you're coming across a new patient. And be aware of your stress triggers and develop ways to manage your emotions. I think in the Power Hayes and McGann article, they suggested a mindfulness practice. So to summarize, nurses can mitigate stigma by being champions and advocates for sickle cell, developing an empathy practice, and increasing exposure to sickle cell to students and future healthcare providers, and mentoring others to become social justice advocates for sickle cell disease, to pass the baton onto the next generation of providers. So now I'm gonna pass the baton back to Stephanie, who's gonna talk to us about our third objective related to shared decision making.
Thank you so much, Dominique, for talking to us about how stigma relates to us in the nursing discipline and how we might mitigate some of the stigma that can often be put on patients that have sickle cell disease, or I should say people that have sickle cell disease. And so essentially you'll see here 3 boxes at the top that are sort of the domains within which we must operate as nurses with our patients and patients with us. And so you'll see the first box, if you're reading from left to right, is communication and relationship building. And this really depends on an individual's characteristics, so the nurses and the patient's characteristics. And this kind of sets the groundwork, the foundation of respect and trust that allows both parties to build a relationship. It also requires that we exchange information. So we ask patients questions we hope that they would answer truthfully. And then patients may ask us questions, and we would know that the patients would like for us to answer truthfully. And then finally, the other part of this domain talks a little bit about the healthcare context. And so, in other words, what about the healthcare system is facilitating for this communication and relationship building, and what parts are barriers to the care that patients could receive, or to the decision-making that patients could be allowed to partake in. And then there's a second domain, that talks about working towards making that shared decision. And in this domain, you have to do some assessment. So assessing the patient's role in the decision-making process, which essentially means, do the patients even want to be a part of making the decision? Do they feel like they want to be an integral part of the healthcare team, or would they prefer that someone else make the decisions for them? This also requires that both parties consider how a person's sociocultural, sociodemographic characteristics might impact their ability to make decisions. So, for example, in the work that I have done, a lot of times in African culture, specifically West African culture, I can speak about, decisions are not made by a single person, but by a group of people. And so considering how that might impact the shared decision-making process is something that we have to take into account. Then there's also the push and pull of teaching and learning. As I said before, we will ask questions of our patients to understand them better, and they will ask questions of us. And so as we're doing that, as we're assessing each other, we are also learning from each other. So as we teach as nurses what we, you think about discharge from the emergency department and what patients could do per se to stay hydrated, as an example. We also need to learn from them about what is their access to having clean water and being able to stay hydrated. Is their job a job where they're outside? Is their job a job where water is around the corner like it is from my office? Or, from the patient's side, they may be teaching us about the ways in which that they have been trying to keep themselves healthy, and we can learn from them as well. Maybe this is a technique that does work for them and just happened to not work this time, but it's something that we could share and learn more about. And then finally, we have to find balance between all of these pieces to make sure that we can actually get to making the decision. So once you have made this shared decision, you actually have to do something with the decision, right? You have to implement this decision that you've made. And sometimes you are able to implement a change or make this decision that you've come to. For example, if it's hydration, once again, you make an agreement with your patient that they will drink, I don't know, two bottles of water in the morning and 2 bottles of water at night to get them started if maybe they haven't been doing very well with their hydration status. But you want to understand too what their environment is. So oftentimes that decision may not be implemented because there are forces in their environment that do not allow them to actually keep their side of the bargain, if you will. And so part of that decision-making process is really working through that process of returning home and figuring out ahead of time what might be some of those environmental obstacles that might prevent them from being able to implement the decision that was shared. So with that, I actually would like to bring us to a close. I want to thank you for listening. And if you have any questions, just please feel free to email us. Our emails are here. And I want to just say thank you. Dominique, do you have anything else you'd like to say?
No, thanks everyone, and enjoy the symposium.
So unfortunately, we don't have them here to answer questions, but I hope you all agree the quality of that video was just as good as if they were here a lot in person. Someone did have a question that they asked, and I want to ask Dr. Tanabe to answer it if she's still here. Paula?
Yeah.
I am still here.
Okay, so the question is, how do we get nurses to treat us with compassion after they have had a negative experience with a prior patient?
Can you repeat that?
Sure. So I believe this person lives with sickle cell, and she's asking, how do we get nurses to treat us with compassion after they had a negative experience? I think she's talking about the nurse has had a negative experience with a prior patient. So she's carrying that experience over to the next patient.
So I think that's a great question. And I think there's a lot of things that as individuals living with sickle cell you can do. And one is to just try to, I don't want to say be nice, but you're in a lot of pain. And I think it's hard to answer this because it's all going to sound bad, right? It's just, we have to give every experience and not take what happened 20 years ago with us every day. I think we kind of have to try to have a clean slate every time, and try to kind of hope for the best, answer questions. I think it takes time. I think the best way really is to be able to let them to get to know you a little bit when you're not sick. So one thing that has worked very well is to work with your emergency department and see if you can come to a faculty meeting or a staff nurse meeting and just talk with the nurses when you're feeling good. Because the nicest individuals with sickle cell and, with whatever, and myself included, when we're in pain, we don't interact really well. So I think that's been powerful to have individual with sickle cell panels during emergency medicine faculty meetings and staff nurse meetings where you're all feeling good. You can give your story, and that is going to be a totally unique perspective for healthcare providers to have. It's not an easy question, and there is no great answer.
So I hope that helped the person that posed the question a little bit. I would also encourage, if you have a local sickle cell disease association, to try and maybe set up something with them to do something with the local hospital. That's kind of how this sort of all evolved. We are having a patient panel later on, and I think it's next coming up to speak just to that, so that our providers in their audience get to see our people living with sickle cell living their life, and not just sick in the hospital. But please reach out to us, if you need any help organizing that sort of event, wherever you are. I'd like to hear back from you later.
I think demonstrating that your disease, your genotype, your hemoglobin, like those things always make nurses feel good, I think. Like I know my medications for whatever disease, whatever you're there. That's all.
Yeah, I think what Paula's trying to say is, and it's unfortunate that you as a patient not feeling well have to go into the emergency room and make yourself unique, speak to your own uniqueness in order to kind of break down that unfortunate lack of empathy, that you may be getting from that provider that day. So we ready to move on?
I think so. I think that was really, really good. And like you said, I wish they were here live. It would have been amazing. But hopefully we'll have them back, and we have their video that will be uploaded to the Hoopla platform to view again at your own leisure. So I will stop the recording on this.